All right, welcome back, everyone. It's been a while. Hope y'all are enjoying your spring break, at least if you're on spring break. For those on the quarter system on the West Coast, I don't think that really applies as much, but you'll get your turn soon. And I just wanted to introduce y'all to our virtual shadowing session. It's been a while since our last session, but we're here to have more. We're here joined by Nick. He's a resident, a third-year resident at the University of Minnesota in Diagnostic Radiology. I think that we've gone through radiology maybe once before, but it's been a while. So this might be a new specialty for many of y'all, and we're very excited to deliver. I do have some reminders for those who are new to virtual shadowing in general or to our program. Just to give you a quick rundown, our program is pretty simple in format. We typically have speakers from a variety of specialties, not just doctors. For any pre-PA students out there, pre-dental students out there, we have speakers in your fields too, and subspecialties within them too. But we have speakers each Monday and Thursday typically. There's some variety with that, and to stay tuned, you can take a look at our Instagram page where we post flyers ahead of time for sessions. But typically it'll be Monday or Thursday with those speakers. We have them present, talk through their specialty. Maybe they might include a little extra outside of that. Some of them have some niche interests, and at the very end, we'll have a Q&A. So for today's session, if you have any questions for Nick, please feel free to type them in the chat and we'll get around to them at the very end. We'll go through them in the order that we receive them. So if you catch any questions as we go at any time, feel free to write them down. Another thing, and the last thing I want to mention before we hop on to Nick's presentation is about our listserv and our Instagram page. So if y'all have heard through a flyer from your advisor or a club of our session, there's another way that you can hear about us to stay in tune with things on a weekly basis. So we have our listserv. It's a weekly email with flyers like the ones that you've probably seen sent out over email. And we have our Instagram page, which again includes those flyers. We do have other programs outside of virtual shadowing for mentorship, for volunteering. Those are not released on a continuous basis. It's really a semesterly basis that those are released. And the next time that those are going to be released will likely be later this fall. So it will be a while from now. But like I said, just in case you want to stay in tune with that, feel free to either subscribe to our listserv or follow us on Instagram. But with that said, that's really all. I do have some last reminders at the very end of today's session in terms of the quiz. So if you have any questions about that, save that towards the end. But let's hop onto the session. Nick, feel free to take it away.
Awesome. Thanks, Michael, for that introduction. So as you guys can tell by this first slide that we have here, we're going to be talking about radiology today. And so if you would like to follow me either before or after this presentation, here's my handle, Dr. Parisis, and we'll jump into things. So basically, I am from Northern California. Went to high school there, grew up there, and also went to college there. I went to college at the University of California, Santa Cruz, where I majored in molecular and cell biology. When I was at UC Santa Cruz, I also played rugby, so I was a collegiate athlete. That was kind of my main extracurricular. And then I took two gap years. I worked in San Francisco at a Google Glass startup. And then I was applying to medical school in that time. And then I went to medical school all the way in Florida, in a city just outside of Tampa called Bradenton. And so I went to the Lake Erie College of Osteopathic Medicine, or LECOM for short, in Bradenton. And then I applied to Diagnostic Radiology in 2020 and matched at the University of Minnesota. So I'm currently in Minneapolis in the Twin Cities, and residency here is for 5 years. So I'm here through 2025. And then the way it works is that in radiology, almost everyone does a fellowship. So I have another year of training after that. So it's really 6 years total. So that's kind of a broad overview of my path. And here's some of my hobbies. I do a little bit of social media, a little bit less now than I used to. Besides, I mentioned rugby. I played rugby in college. I also play traditional Greek folk music. So I do this like for weddings, baptisms, dance competitions. So this is like my other main hobby. So just a reminder, don't forget to keep up your maybe more creative pursuits as you're going through this kind of nutty process of learning medicine, basically. Medical school can feel like you're drinking from the fire hydrant. There's just like way too much volume of material that you have to know. It's all learnable. The concepts aren't, you know, you don't have to be a genius to understand them, but it is like drinking from the fire hydrant. So every day you have to come in from the side and take small sips is the idea. Here's another analogy. You know, some people think like it's like eating a stack of pancakes every day. Like you have to continuously like work at studying. Like and now I'm, you know, I'm 3 years out of medical school, and you still do have to study. It's a lot of studying. There's a lot to know, no matter what specialty that you're in. This is a quote that I like, just to kind of remind yourself about the things that are like actually important in life. You know, life is like kind of juggling 5 balls or 5, you know, glass balls in the air all at once. And so those balls can be different for different people, you know, at different points in your life, of course. You know, work is a rubber ball, though. You know, if you drop it, it'll bounce back. Some of the other things like your health and like your relationships with your spouse or your loved one or your family and friends, those don't always bounce back. So just, or like if you play music or have some other creative hobby, you know, you can't just like totally drop it because you might not get it back. So anyway, so this is just what they call these, like a word cloud of some adjectives some words that come to mind when people think of certain specialties. So you can see here kind of where the radiology stereotype lands. And, you know, I'll let you decide for yourself whether or not this is true as you know, go through your rotations down the line in medical school and all that type of thing. So kind of the stereotype is that we are antisocial, don't like to talk to people. We sit in a dark room and look at images, which is partly true, but it doesn't necessarily mean that we're antisocial. And you know, every specialty has their peculiarities and their quirks. Let's see. Oh, did I skip a slide here? Oh, yeah. So this is another kind of, you know, stereotypes of what people think that radiologists do. Basically, you know, what we really do is diagnose. Sorry, there's a little bit of lag here. Let's see. Okay. Basically, we look at images and make diagnoses for patients is kind of the core of what we do. We also do a lot of other things. This is a broad overview of the history of radiology. So X-rays were kind of discovered around the turn of the century. But we've also added things like ultrasound, CT scans, MRI, and other types of imaging like nuclear medicine and breast imaging. We've added a huge arsenal of different imaging modalities to diagnostic imaging. And so over the years, you know, radiology is continuously changing just because it's like kind of at the bleeding edge of technology. So at first we had, you know, computerized X-rays. Then the X-ray film went away after that. Then we had transcriptionists, voice transcription software. That went away because we have a dictation software now, like Dragon Dictation that we use. You know, about 20 years ago, the use of CT scans has exploded. Like the volume has dramatically increased. So CT scans have gone a lot better. MRI has also gone a lot better. So they say that the art of the physical exam is forever lost because now you can just scan a patient and get, you know, arguably more objective data point for you know, whatever's going on with the patient. And kind of artificial intelligence is the next big thing. So we can talk about that too if you guys want. This is the very first radiograph or X-ray that was taken. This is a German physicist. His name was Wilhelm Röntgen, and this is his wife. I think this was, I can't remember if this is his wife's hand or if this was his wife's hand. Either way, his wife's hand was the first image. The second image was taken 3 weeks later, and that was his best friend's hand. So either way, they were both wearing their wedding rings, I guess. So radiology is kind of the eye of medicine. You know, we're able to obviously see inside of the body, which is like pretty cool, you know, without having to cut someone open to do that. We have a lot of imaging modalities. Here are some of them here. It extends from X-rays to, MRI, CT, ultrasound. And like I said earlier, we make diagnoses, but we also do a lot of procedures. We also do treat certain diseases. I'll talk about those down the line. And basically, we help guide the clinicians and the surgeons who are kind of more on the front lines. We help them make decisions, is the idea. So basically, the report that I generate after looking at a set of images is going to be used by them in order to make decisions about patient care. Do we change this patient's chemotherapy? Do we take them to surgery or not? That type of thing. Do we keep it with conservative management, or become more aggressive with our therapy? So, we make diagnoses, we do procedures, we do see patients actually, and we actually have to know a lot about physics. So just keep that in mind. Here's just some examples of what these different imaging modalities actually look like for the skull or the brain or the head, for example. So just a regular plain of the mill X-ray or a radiograph looks like this. This is what a CT might look like. MRI, you get a better picture at the brain tissue, like inside here. MR angiography, here we can look at the blood vessels themselves, the arteries specifically, a lot better. This actually might be an MRV, a venogram. But anyways, and this is a PET scan where we look at the metabolism of the different tissues. So, that's kind of the basics, or a really broad overview, I guess. This is kind of what the day looks like. So we do spend a lot of time sitting. We do have really, really cool workstations. We have like these $10,000 or $20,000 monitors. They're like 6K resolution or something. So they're like diagnostic monitors. And our day is kind of broken up by the different things that we have to do. So we might be frustrated throughout the day. We might take a coffee break, or drink our coffee while we're dictating and looking at our studies. I guess the day starts here at breakfast. And your day is interrupted with, phone calls, questions from other doctors, questions from other radiology technologists, talking to patients for procedures, for consenting them, for protocoling, which basically means like customizing a scan so that it's very specific to what the question being asked is. So, if you work at a university medical center or in academics, you might do a lot of teaching to residents, for example, or to medical students if they come around. You'll definitely spend time on the phone. The phone is very busy during the day. And then you might have like a research day, just depending on what type of job that you have. And if you're, for example, an interventional radiologist or a breast radiologist, you might spend time in clinic as well. So, radiologists at home at night. And the joke is, we do spend time in a darker lit room, but the reason for that is so that our eyes, when we're looking at the photons or the brightness coming from the screens that we're looking at, it's so that our pupils can dilate and so that we can get more light into them, so that we can see the contrast between the tissues a lot better. That's the reason for keeping the room a little bit dimmer. It's not pitch black, obviously. This is just another meme. I'll just kind of blow through this one because I have a lot of these images. These are the daily activities of the medical doctor. As you can tell here that, you spend a lot of time not doing patient care, is what I quickly understood as a medical student. And so I just feel like in radiology, you get more of the essence of what I felt like medicine is. Administrative tasks, not fun, and you can kind of see where radiology falls there. I think this is a positive. Career in medicine, radiology is like taking the center of the Oreo right out, just because you're leaving a lot of these other things behind. So I wasn't really interested in doing some of these things. And some people, their character or their personality might not be suited for radiology, and that's fine. There's other specialties where people get this. They get the essence of what they feel like they want to do in medicine. So there's quite a few reasons why I personally chose radiology. I'm asked about this all the time. So one reason is just like the impact on patients. So like you can see more patients per day. Like for example, you might read anywhere from 50 to 100 different scans. So that's 50 to 100 different people that you're helping really. Um, like I said earlier, less administrative tasks. So you're really focusing on like the anatomic pathology, right? So you're not doing a lot of these types of things. You're not like placing orders or like writing prescriptions and that type of thing. Um, the breadth and diversity of the branches of medicine that radiology touches is pretty much every branch of medicine, maybe except for psychiatry, even though sometimes psychiatric patients will get, head and neck imaging to rule out like other more organic causes of their symptoms, like a more medical cause, like a tumor or something. So this I think makes radiology really cool because we kind of get like the best cases from every specialty. So we get patients that are very, very complex, very sick in the hospital. We also get patients who have very, very rare diagnoses. And so I think this makes it for a very interesting specialty. That said that, there is a lot to know. So you really have to know a lot. So it's kind of a double-edged sword just because of how broad the knowledge base has to be. I feel like radiology is very innovative, cutting edge. I talked a little bit earlier about the history of it, how it's constantly changing. And because of that, there is a big emphasis on teaching and research, and like I said earlier, studying as well. So you really can't cram it all in. It comes slowly over the years, I guess. So would you choose the same specialty over again? I mean, I think this is pretty straightforward. I think this is a positive thing. I don't know if this is necessarily accurate. I think it's based on like Medscape or something, but this is from 2018. I think radiology, yeah, it's ranked up here number 3 on this pain scale of how good or bad people think that their job is. So again, I think we're doing okay. So when I was a medical student, I noticed that other people would switch into radiology from many other different specialties for different reasons, really. People would come in from internal medicine from vascular surgery, orthopedic surgery. They would, switch into radiology, but people wouldn't really switch out. I didn't really see that happening. So I thought that was a good omen. I also found that diagnostic radiology is a very cerebral workflow. So I'm not someone necessarily who needs to like work with my hands. Some people really need that or like really want that out of a career in medicine. But I'm like totally content, like just doing a handful of procedures during the day or like none at all. Like I'm okay with that. I really enjoy the diagnostic part of it. And so that's a lot of thinking, basically, is what I'm trying to say there. Are you more of a thinker or are you a doer? Or if you're both and you want to do both, then we have that as well. So I think we have a lot of flexibility in radiology. So where we work is called the reading room. And so there's different like workstations with like these big monitor setups with like 4 or 5 different diagnostic monitors on a big workstation. And there's like, there's anywhere from 3 to 5 different workstations in a room. And so the reading room is kind of a lower stress, less noisy environment because we really do need to focus when we're looking at these images. So I wasn't really interested in like having a lot of things going on, so to speak. I think our colleagues, generally speaking, are like pretty easy to get along with. I think people are like pretty laid back and humble. So another positive for me. And I think at the point that we are now, I think imaging basically really is the physical exam of the 21st century. 100 years ago, they would do this very extensive physical exam, and now we have this awesome test of a scan to like really, be a lot more confident with what we're diagnosing. It's not to say the physical exam isn't important anymore. It's actually extremely important, but sometimes patients, they can't cooperate with the physical exam because they're obtunded or they're a trauma patient, they have a breathing tube in, et cetera, and so on. So you have to scan them, and oftentimes we'll, find occult fractures or, things that they didn't even know that they had. And this can be a, double-edged sword as well. There's these so-called incidental findings as well. You do learn a lot about the physical exam in medical school. It is important. I'm not saying it's not. But imaging is actually very, very important in clinical practice as well. So a few more reasons. So I talked a little bit about career flexibility, or like flexibility in general with like procedures and diagnostic work. There are a lot of fellowship options, which I'll talk about later. So basically a lot of opportunity to subspecialize or not to subspecialize if you want to be a more general radiologist. And you can kind of customize your career to have as much or as little patient interaction as you personally like, and that can change over your career as well. Um, some people liken the radiologist to the doctor's doctor, but other specialties have said this about their specialty as well. Because you are basically a consultant, but you're a consultant or a specialist for imaging, so that's kind of what people come to you for. So I think this is a pretty cool position to be in. But again, other specialties like might refer to themselves as the doctor's doctor, because other doctors might be coming to them with questions if they're also some sort of specialist, right? One thing that is very unique or somewhat unique is being able to do remote work or work from home with teleradiology. So we were probably one of the first specialties to start doing this. And I think it's because it is very much a computer or a desk job. So I found this to be, I think this is a huge positive, but some people don't see that as a benefit, which is fine. Some people don't want to work from home, or, for one reason or another. And a lot of jobs these days are a mix of working on site and working off site, which is kind of the best of both worlds. And this is kind of what most people seem to want, is to be able to work from home, but just not all the time. Yeah, so basically, I think in radiology we have a lot of flexibility. We have work-life balance, and I think this makes for a nice nice career, and a nice career where you have some longevity, where you're not going to get necessarily burnt out too quickly. I did forget to mention that radiology is shift work. So basically, I don't take any work home with me, which is pretty awesome. I was never really interested. I was interested in having a nice line in the sand about taking work home with me. Like, I didn't want to like have a pager on me like when I'm not working, and basically when I am working, I want to be working. Like, I don't want to have my attention divided or whatever. So how many weeks of vacation? This is a good question. In private practice, it's not uncommon to get more than 7 weeks of vacation. In academics, you might get like around 5 to 6, but throughout the week, they may have like a 4-day work week because one of their days is an academic day or a research day. So, and in private practice, I mean, I've heard of some jobs where they can get like 12 to 15 weeks of vacation per year. So it's pretty good in that aspect. I think anesthesiology does really well in that regard as well, and so does emergency medicine. And I think that has to do with the fact that all of those specialties are shift work. So just keep that in mind. Some non-medical aspects here that I've listed about radiology. Depending on what type of job you have, you may read like 100 scans in a shift. So what does that mean though? You might read like 10 MRIs, 30 CT scans, 50 X-rays. Let's see, what is that up to? And the rest ultrasounds or whatever, and maybe like a PET scan or two. Just depends on the job. You may only read like 30 MRIs. That may take up your entire day, or you may only read 20 PET CTs, or you may read 150 studies. If you're reading mostly CT and X-ray and ultrasound, and you're not reading a lot of MRI. So it just depends. It really depends. The hours that you can work also vary tremendously depending on the job. You can really grind and work really a lot if you want to pick up more shifts and basically make more money is the idea. So some radiologists will work 60 hours a week, and others decide to work below full time. Some want to be like a 0.7 full-time equivalent, so they may work 30 hours a week. And so I think that's pretty nice to be able to have that flexibility and to basically be able to work more to make more, or do the opposite, really, depending on what stage in life that you're at too. You can change that. I talked about vacation. The salary is relatively competitive when you look at other physician salaries. I think this is a positive thing too, because I mean, a lot of us have like just student loans that are like insane, uh, or we have family or want to live in places that have a high cost of living. So I don't think that salary should not be thought about or talked about. So just, I mean, it shouldn't be like the number one thing to think about, but it maybe it shouldn't be the last thing to think about either. It should be somewhere in the middle. Um, in radiology, your job really varies depending on whether you choose to go into private practice or into academics. It also varies a lot whether you go into like a metropolitan city. You're more in a rural environment versus an urban environment. So if you're more rural, then you're much more likely to be a generalist and to kind of do everything, a little bit of everything. If you're more in an urban environment, then you're much more likely to be a little bit more specialized or a lot more specialized. Similarly, in private practice, most private practice groups are a little bit more generalist, and in academics, it's a lot more specialized. Um, Compensation, another Medscape survey. I think this is pretty straightforward too. So, if you're wondering what type of procedures that radiologists do, it depends on what you are subspecialty trained in. I have some of the subspecialties in radiology listed here, so just keep these in mind as we go on to the next few slides. So musculoskeletal imaging, musculoskeletal radiologists do all sorts of joint injections, so we can put a little bit of steroid in to relieve someone of their joint pain, for example. They do other procedures as well. I'm just listing like one for each specialty just to kind of get through it. In neuroradiology, we do lumbar punctures to take a little bit of spinal cord or brain fluid in order to test that for things like infection or inflammation. In pediatrics, sometimes the bowel can telescope on itself, and that can be like an emergency. And so, in order to reduce that, to make that come undone, basically, they can do what's called an air enema. And so that's an emergent procedure that a pediatric radiologist might do. A body imager and abdominal radiologist might place an abscess strain. They do a lot of fluoroscopy, which is basically like a live x-ray where you're working with the patient to take a picture. In breast, they do a lot of breast biopsies. They do other procedures besides biopsies, but this is kind of the core of it. And in breast radiology, obviously the number one thing that we're looking for is breast cancer and the different types of breast cancer. And then there's interventional radiology, which is kind of this wild card. They do over 200 different procedures. I have some of these listed here, but I just think IR is a really, really cool specialty if you're interested in procedures. And so it's like many things, it's a double-edged sword. The reason to do it is because you love working with your hands. But if you don't like, wearing the lead suit, being on your feet, constantly doing procedures, then maybe not for you. But like I said earlier, there's a lot of flexibility in kind of how you can craft your career and how much or a little procedural work that you want to do. This slide is talking a little bit about the path to becoming a radiologist. So it's a really long path. So it's a longer residency than most. It's minimum 6 years because almost everyone does a fellowship. These are the fellowships that people do. Most of these are 1 year long, except for neurointerventional radiology. That one's a little bit longer. So you have, 4 years of high school, 4 years of college, 4 years of medical school, and then you have a year of internship that's listed right here. You have 4 years of diagnostic radiology training, and then you have fellowship. So all in all, you're looking at probably 14 years, after high school. So it's quite the path. But everyone says it's worth it at the end. This is probably less relevant to you guys now at the pre-med level, but this is more of a residency thing. I'll talk about artificial intelligence in brief. You can watch some YouTube videos on it. I think there's some decent content by some radiologists out there. It's very exciting. People have been saying that AI is going to replace doctors since like the 70s. I think there's like been an old white paper that talked about it then. And besides like taking over what we do, there are a lot of hurdles to overcome. I have some of these listed here. I can talk about these in depth. I could probably talk about this slide at length for 20 minutes. But there's way like less complex things that we can have AI do. We can have them like we can have it do scheduling, like triage studies. Like, hey, is it seeing something in the scan as soon as the images are acquired that a radiologist like needs to look at this like immediately or stat. So it can kind of function as like a pseudo triage. And right now, basically, the application uses are very, very narrow. So it can become the AIs that exist in radiology are very good at potentially only one thing. But we're rarely only looking at one thing. There's like multiple different findings that we're putting together in order to come to a diagnosis. You also want to think about what would a patient want? What would I want for my mother, my mother-in-law, my grandparents, et cetera, and so on. So basically, the bottom line is that AI is going to supplement the radiologist to improve patient outcomes. It's going to be another tool in the toolbox, basically, to help patients. And because of that, radiology will look very, very different in the future. Another big hurdle to overcome is the legal issue. Like, who is going to take responsibility for that? Is it going to be the engineers, the software people, the tech people who designed the AI? Is it going to be the hospital who bought it? Is it going to be the radiologist who's using it? So I think it's a little bit complex there. This is the AI is replacing doctors starter pack, another meme. Basically, it's mostly people who don't work in radiology who think that this is going to happen. It's actually kind of comical. I mean, the phone is going off all the time at work, like that alone, or like my dictation software, like it doesn't register, like it misspells a lot of the things that I say. Like until we can get like really basic stuff like that down, I don't think our jobs are going anywhere. So there's a few misconceptions, that radiologists are socially awkward introverts, that we don't see patients, potentially that radiology is easy, and that AI might replace us. Obviously, I don't think really any of this is true. We have all sorts of different type of people in our specialty. We do see patients, we do procedures. It's a 6-year residency program. So I don't think that would make it an easy specialty by any stretch of the imagination. So let's see, let me check the time here. All right, so we're almost at 40 minutes. At this point, I have basically a bunch of imaging, and we can take questions here. I can just blow through some imaging just so you guys kind of visually get an understanding about what we do, or like kind of what we think about throughout the day. So how does that sound, Michael? Maybe I'll just kind of blow through all of this imaging so that people can see what we see.
Yeah, absolutely.
Okay.
A lot of students love this part of the presentation. So yeah, let's go for it, and then we'll go through some questions afterwards.
Perfect. And feel free to interrupt me if we're taking too long. So this is a chest X-ray. Basically, things that are more dense are wider, things like bone or soft tissue like the heart. And then things that are darker are things like the lung. So the lung contains air, obviously. So that's why. And then a lot of the anatomy is overlaid here. Obviously, when I'm looking at a chest X-ray, it's not labeled like this. So you kind of have to know all of this stuff. This is just another diagram kind of, visually showing you some of the anatomy. Stomach sits down here, the spleen, liver, all of these vessels coming through. And this is kind of how we think about an X-ray. Things that are darker on the X-ray are typically air density, and then things that are brighter, things like bone, calcifications, kidney stones, gallstones, for example, calcifications from atherosclerosis from the vessels, or like devices like a shoulder replacement or a hip replacement. Those are going to be a lot brighter, right? And then things in the middle are kind of that spectrum of gray that can be sometimes difficult to interpret. This is just a standard normal chest X-ray, or chest radiograph is the other word for it. We look at the trachea as it comes down here and bifurcates into the carina, and then into the bronchi here. These are your airways, of course. This is the cardiac or the cardiomediastinal silhouette. This is the heart, basically. This is the left heart, and then this is the right heart. So this is the left side of the patient. This is the right side of the patient. And then here we're looking at the lung fields, this dark stuff here, all of this here. And you can kind of see some lung markings. They actually come down here below the diaphragm a little bit on both sides. As we come down here, you can see the diaphragmatic contours here, the diaphragm here. This is called the costophrenic angle or the costophrenic recess. Sometimes fluid can collect in here. And then kind of at the outskirts is where we look at the pleura. So some of you guys may have heard of like a pneumothorax or like a collapsed lung. So that's kind of where we would catch it. It's kind of at the edges of the film of the X-ray. We also look at the upper abdomen. So this bubble right here, this air density here, that's gas in the stomach. That's called the gastric bubble. We know that the spleen is a little bit dense, so that this is going to be a little bit wider here. The liver sits over here. You can see that the right diaphragm is a little bit higher than the left. That's because of the liver. It's kind of pushing that right diaphragm up. Then you have some soft tissues here. You can kind of see some soft tissue planes here. And then we also want to look at the bones. So basically you have like, we're not getting the shoulders in there, but you would have like the glenohumeral joints, your scapula, your acromioclavicular joint would be out here. Then you have your sternoclavicular joint as your clavicles come medially or more centrally here. You have all of these ribs. Obviously, you can see all of them here. You have your anterior ribs, and then these are your more horizontally oriented posterior ribs. Most people have 12. And then you can see a little bit of the spine here as well. Not that great, but you can see the spine. Did I skip over? Anyway, so basically when we're approaching a study, we have like kind of a systematic checklist in our head of like what we're gonna look at. We're gonna look at the trachea, the heart, all of these vessels here, a little bit of the aorta as it's coming down here. We're going to look at the lung fields. We're going to look for any fluid in the lungs. We're going to look at the upper abdomen, the soft tissues, and the bones, right? We have like kind of the systematic checklist that we go through every time. So that way we don't miss anything. This is a similar idea for CT scans. Basically, a CT scan is like a really fancy X-ray where we're looking at the densities of things again. So air would be really dark, and then things that are much denser, like bone, would be a lot brighter. And then soft tissue is kind of in the middle. And then arbitrarily, water is designated as like 0 or like the value of 0. So again, this is kind of demonstrating that again. So this is called a Hounsfield unit basically. And so water is arbitrarily 0. And then we have different values that we generally know about where like we kind of know what the value is. So you can see like obviously bone is a lot brighter than like the brain tissue here. And then this would be like a little bit of intraparenchymal hemorrhage. So this is basically a bleed in the brain or a certain type of stroke. So you can see what density that it is here, but you can also just see that it's a lot brighter as well. It has a little bit of edema around it here, a little bit of swelling basically. And yeah, and then you can see here kind of the skin here, and then the subcutaneous tissues have a little bit of fat basically. So this is like the scalp, right? So fat is less dense than all the stuff in here. And so that's why it's appearing as dark. And then air obviously is not very dense at all. So this is like air that's external to us. So moving on, this is just a chest CT. Again, some of the anatomy, just so you can get an idea. We look at, the anatomy and all of these different planes here. This is just a case of a patient with pneumonia. So I kind of have all of the clinical findings here listed out, but I'll just kind of blast through this. So basically, we're just seeing an infection right here is the idea. This is what COVID might look like on a chest CT. This is what congestive heart failure might look like. So basically, this is when a patient has their heart is not pumping very well, and so a lot of fluid gets backed up into the lungs. So you can see that the lungs are not dark anymore. They're actually filled with fluid, and they're very, very bright. So this is like pretty severe pulmonary edema or heart failure. Okay, so in radiology, we say one view is no views for this exact reason, kind of straightforward. And so this is our second view when we look at a chest x-ray. Basically, you want to look at it from the side as well, because you want to look behind the heart, you want to look behind the sternum, and you want to look behind the trachea that comes down here. So there's all these spaces, and so if you're only looking at one image, then you're only getting like half of the story is the idea. And so again, if you're only looking at it from one view, then you're only getting half the story. So just some anatomy, hand x-ray with some anatomy, cervical spine x-ray. So we really kind of read everything in the body, which is pretty cool, I think. That was the elbow there. This is a breast MRI. This is maybe what a breast cancer might look like. This is an abdomen and pelvis CT scan. This is an abdominal x-ray. Abdomen CT, just with some anatomy overlay. This is what an MRI might look like of the abdomen, so kind of similar cut in the body, if you will, just a different imaging modality. So MRI is pretty cool. Pelvic X-ray, we get a lot of foreign bodies in radiology that we have to potentially figure out what they are. Let's see, this is what a herniated disc might look like. So these images are just really nice because they're annotated. So if you like these images, definitely go check out the radiology guy over on Instagram. I think he has some really nice diagrams. And yeah, this is kind of close to the end of my presentation. So this is a case of multiple sclerosis. Basically, you get these like little plaques is what they call them. And so they're kind of, these globular, like they call them Dawson's fingers. They're like little projections coming out. And so these are seen in multiple sclerosis. So you may know a family member with multiple sclerosis. This is another type of brain bleed. This patient may have like slipped on ice and had a fracture to their left frontal bone there. And then you can see kind of how this bleed is a lot darker or a lot brighter than the darker brain tissue right here. And you can see how it's kind of like pushing all of this tissue here. There's like all this mass effect here. A little bit of swelling probably. Let's see, this is a video. I'll skip through that. Let's see, well, let me skip. Cool. And so here's some resources that I like. I don't know if anyone wants to screenshot any of this, but if you are interested, there's some social media accounts you can follow, some websites, podcasts, that type of thing. I think this blog is awesome. And maybe this stuff will be more helpful to you guys as you get to medical school. So a lot of black, it's not just black and white in radiology, a lot of gray area. And that's all I got. So I hope this is helpful.
Yeah, for sure. Well, we really appreciate the cases that you've included. And I really like the images too. Some of our speakers, they go through things, kind of word by word with presentations, but it's always great to have more visuals to it. So first thing, being in your residency in diagnostic radiology specifically, I know that there's also interventional radiology. Did you happen to ever consider that route?
Yes and no. I considered it, but I quickly found out that I am not. I was not interested in becoming a proceduralist, really. I was never interested in it. That said, I still did an interventional radiology rotation as a medical student because it is a part of radiology that we have to know about. And because I do think it is very, very interesting. I mean, they do some awesome procedures. And not a lot of other doctors don't really know what IR does because some of the procedures are so advanced. So I think it's still worth doing a rotation in, even if you're not interested in doing it as a career. So yeah, so that's the first reason. I didn't do it because of the procedure part of it. Like I wasn't interested in doing so many procedures. The second part of it is that they take call. They take like a weekend call. So it's a little bit, I wasn't really interested in doing that either. I'd rather have, my diagnostic shift and then not have a pager, so.
Yeah, definitely. That's some insight for us too, because personally, even myself, I didn't even notice the differences, the nuances there with work style. I didn't know that they had call with IR versus no call with diagnostic. I didn't add that up, so that's good
Well,
to see the.
I should say that diagnostic call is different because when I'm on call, I do have a pager, but when I'm done with my shift, I'm not taking work home with me is the idea. So I'm not going to be on call for like, the entire weekend, for example. I might be on call for like 9 to 12 hours and then I'm done with my shift is the
Oh,
idea.
gotcha.
Yeah.
Okay. Okay.
So, when we say call in radiology is a little bit peculiar, because it just means that you are doing like emergency radiology is the idea. Like when you're on call, you're kind of fielding everything that's going on in the hospital. So
Mhm. Okay, that clarifies a bit. Another thing is, and again, being in residency, I'm sure that you went through this pretty recently. Uh, you mentioned the away rotation that was it an away rotation or just a rotation at your home hospital that you had?
yeah, yeah, I did do away rotations.
Okay.
Yeah,
So in terms of actually getting into the specialty, I'm sure that's a big part of it, right? Having the actual exposure. Were there any other things that you think made your application compelling going into residency?
yeah. So some of you may know now. I think starting in 2022, like radiology became extremely competitive. So I matched in 2020. And it was as competitive as it had been the past like handful of years. But this past year and the year before that, it like has absolutely exploded in popularity. So unfortunately, I think doing an away rotation is a double-edged sword. I think in radiology, it's mostly probably a wash. Like I don't think it helps that much, but I do think that it can help. It can help you get an interview. So the reason I say that is because radiology is a little bit peculiar because as a medical student, if you're on like a surgical rotation, you can like become a lot more hands-on, like in the operating room, for example. Whereas in radiology, you are not really like that helpful per se. So um, there's not much that a medical student could do basically to like help with the work is the idea. So for whatever reason, I think an away rotation just basically helps signal to a program that you are interested, but I don't know that it really helps that much in like your rank, like when they come down to ranking you. It might help a little bit, but I don't think it helps that much. Now, what I personally did was I did do some away rotations because they did help me score some interviews. But I think the key now, like, and I'm saying this as the key because it's so competitive now, is really knowing someone. I think networking is the key. And so, yes, you can network when you're doing an away rotation, but I think you have to take advantage of your network too. So that's going to be in terms of like going to conferences and meeting people, interacting with people in the specialty. That can be through social media or having a friend and like asking them questions. It can be doing research with a mentor. That mentor doesn't have to be at your school necessarily, or they can be at your school. You can have another research mentor at another institution because as we all go through this process, as you can tell, like people know people, and as the further you get along, like the circle gets a lot smaller. So as soon as you get someone who can vouch for you, who can write you a strong letter of recommendation, and so once you start building out that network, I think that is kind of the key because everyone's going to have good grades at this point. Everyone's going to have a good USMLE score. Everyone's going to have some research, some interest in the specialty that they've shown. And so that's, I think, what helped me stand out because I had a mentor who put in a good word for me here at the University of Minnesota. And when I came to interview, I was like, oh, wow, I actually like the city a lot more than I expected. The program really impressed me. They kind of had everything that I was looking for. And so I ranked them high and here I am. So super, super thankful for him, so yeah, basically networking. I think it just who unfortunately, or fortunately for some people.
Yeah, that is definitely a big truth. We've heard it on a few sessions now, and it's definitely a big theme, I guess, of residency. Definitely not the case for medical school. It's kind of weird to think of medical school as being a networking game because there's just so many applicants. I think over the past 2 years, there's been something like 60,000 applicants. That's been a 20,000 jump since what it's been in the past. There used to be just 40,000. So with so many people, you can't really network like that, but definitely a different
Yeah.
game with residency. Another
Yeah,
thing
absolutely.
is you took a gap year, right, before medical school. Can you take us through what you did during that gap year?
Yeah, so I took 2 years off between college and medical school. So so basically, I graduated and then I took about 4 months to study for the MCAT. And so the first 2 months were a little bit lackadaisical, kind of half days of studying. And the next 2 months, I kind of, ramped things up, blah, blah, blah. And so I really wanted to dedicate that time to taking the MCAT and giving it the attention that it deserved from me. Some people may only need to study for a month or for 2 weeks or whatever. If you're a genius, I'm just like a regular guy. Um, so I took the MCAT. The next thing I did was I got a job, and then in that time while I was working, I was also applying to medical school. So I was like writing my personal statement, collecting my letters of recommendation, sending all that stuff out. Writing your little essays and your little blurbs about like what you've done, your extracurriculars, volunteering, research, all that yada yada. And so all of that takes a lot of time. So I basically like spend my nights and weekends like doing a lot of that. And then once you send your applications out, then you're interviewing. So would spend thankfully I was working. I was able to pay for a little bit of flights and hotels and rental cars. And so I think I went on like 7 interviews or so. Um, and then I think before starting medical school, I took a couple months off to do some traveling, and that's how I decided to use that time.
Cool. Yeah, definitely. Traveling time is definitely needed. Once you get around to that point where you got the acceptance, I mean, lay back, take it easy because it's going to be a rough well, 4 years, not just a few years, I guess. Another thing is following that gap year, what was the learning curve for you like in medical school? I know a lot of people say that it's definitely a big jump going from undergrad to medical school in terms of your study strategies and all. How was that for you? Do you make any particular changes, use any particular tools to up your study game?
Yeah, I definitely did. I agree. With whoever you've talked to, it's a slap in the face for sure. It's a very, very abrupt change. I talked a little bit about it earlier. It's like drinking from the fire hydrant. Um, Basically, whatever you did in college and in high school, that is not gonna cut it. Basically, what I found that worked for me is that I had to do flashcards, and I had to do a very particular type of flashcard called Anki. So some of you guys may have heard this. It's called ANKI. You can look into it. It's basically like a dedicated flashcard application that basically it times out, it spaces out like, okay, 3 days, 7 days, 10 days. It's gonna remind you to do that flashcard so that you almost never forget it, so that you are able to remember 90% of the flashcards that you're doing. It has this kind of spaced interval built into it. And honestly, I find that that's still working for me now. So that's like probably the number one thing. Obviously, there's a lot of other things that you'll find everyone else is using in medical school, like certain question banks. So practice questions are really good. I think you do need to do a little bit of reading, like textbook reading too, just to get like kind of the fundamentals too. There's certain videos that people use. There's certain mnemonics, like picture mnemonics, like Sketchy that people use, and you'll learn about those once you get to medical school. But yeah.
100%. I'm actually using it at the moment right now, but I guess it's been too late right now in my gap year. So for any of those listening, if you're going through any courses right now in college, I think that's definitely a huge advantage in terms of any like memorization heavy courses, biology, maybe not as much for conceptual courses like math or physics, but for sure biology. I wish going back I would have used it. Another thing, and just to wrap up our session today, looking onto the future, do you plan to take a fellowship or what's the game plan for you once you wrap up your residency? Do you plan to stay in the Midwest or are you planning to stay in academia versus private practice?
Yeah, I mean, thankfully or hopefully, what I say doesn't lock me in. But So I think about 95% of radiologists do fellowship now. So it'd be the exception to not do one, basically, is the idea. So I'm personally going to do, or planning on doing, musculoskeletal radiology. So I am personally interested in moving to California because that's where I'm from. My wife is from San Diego, so I think we'd be very happy in plenty of the different cities in California. From Sacramento to the Bay Area to LA and in San Diego, for example. Um, so probably not going to stay in the Midwest is the takeaway message. As far as academics versus private practice, I think the plan is private practice right now, but that might change depending on what the offers are that I get in 2 years down the line. Because one thing you want to think about is public service loan forgiveness. I can't remember which letter comes first. But if you do work in a nonprofit setting or like an academic institution, then you can qualify for that too. So that's why I haven't completely ruled it out. And I do enjoy teaching. But sometimes the bureaucracy and the research aspects can get in the way of what you want to do, which is maybe sometimes just do clinical practice. So yeah. And generally speaking, the salaries are higher in private practice. So even though that you might get some of the student loan forgiveness in academics, sometimes the salary differential can make private practice more, financially worth it. So there's a difference there too.
Well, I really do appreciate the time you've taken to get this presentation together, Nick. Maybe we can hear some thank yous in the chat from those who are listening in. This has been a really nice session, especially over a specialty that we haven't seen, at least in a while, if not ever so far on sessions. So it's a great introduction. We love the memes, we love the cases, and we really do appreciate you taking the time to answer our questions. I do have some last reminders for those who are listening in terms of our quiz. So we have that quiz now posted in the chat box. It's also on our website under the virtual shouting page. Either one, it's the same quiz. It's a Google form with 10 questions, and to pass it, you need at least 6 or more of those correct. So that quiz will be due on Sunday, March 19th, around 6 days from now. We typically have that deadline 6 days from now, just because on that 7th day, we'll have our next shadowing session. So in general, we typically have our quizzes due the day before the next shadowing session, if that makes sense. After passing your quiz, you'll receive a certificate. That certificate will go to the inbox of the email address that you list on the quiz. So be sure it's one that you're comfortable with. We really do recommend a personal Gmail or Yahoo account. Any personal email will work. And if you don't happen to find it in your inbox folder, please do check your spam folder. If you don't find it in either, feel free to send us an email. I've included our email in the description below. And the description below, by the way, to our video, which is now released, it also has our quiz. So there's a couple places that you can find our quiz, but feel free to send us any emails regarding any questions for your certificate or other programs that we have at Hearts for Health. We're going to be happy to answer those questions. Our next shadowing session will be later this week on Thursday with Dr. Bera. She's an ICU pediatric hospitalist at Valley Children's Hospital in California. So we'll see her later this Thursday, March 16th, same time, 7 p.m. Central. And we will soon post her flyer if you're interested in learning any more details about her or the specialty that she's in. Like I said, Instagram and our listserv are great ways to stay in touch with us. Either one works. We essentially release the same content. And like I said, any questions we're happy to take. But again, thank you, Dr. Or I'll say Nick, for taking the time to go through this. Do you have your handle? I'm not sure if you have your handle, but if not, if you want to just shout it out for any students to check out your content.
Sure. Thanks, Michael, again for organizing all this. Yeah, guys, I really do think that radiology is the best kept secret in medicine. My handle is listed on a lot of my slides here down at the bottom left. It's just Dr. Parisis, just my last name. And if you do have any questions, any further questions about anything we talked about or anything that we didn't get to talk about, feel free to send me a message because I do check it. I do check it regularly. And if there's a topic that you're ever fuzzy about, just let me know because I know the process is very it's a little bit nutty.
Yeah. So, well, we do really appreciate Yeah, we do really appreciate you taking the time to make this presentation and offering your help. Well, I guess that wraps it up, y'all. So we'll see you later this Thursday. Again, Nick, thank you.